With this final session, we have a big panel here in front of you. Our theme of the event, the main theme was, what is your role? And what is your role? You can take it personally, and I think that's really important. Think for yourself, what can you do to do this important work, what is really needed, and what makes big changes in the world. But another role is the role of organizations. And actually, there has a lot of information been in the press, also in the Netherlands, in the last couple of years, about when they're talking about development aid, they're talking about organizations that are almost fighting with each other. Who will do what? How shall we do it? How can we improve things? And they do not really cooperate. So we thought we tried to get some of the organizations, it's not all of them, but some of the leaders of international organizations here together to think about the future together, the future of global surgery. And I'm really honored to have this really impressive panel of people that are defining the future in global surgery in the coming years. And I will introduce the chairs, and then the chairs will introduce the rest of the team and explain you how it will work. We try to make it not too long, so it has been a long day, but it would be great to think how we can move forward together. So I introduce to you Hugo Heij and Edna Edan. They will be the chairs of this session. I hope you enjoy.
Thank you. Well, thank you very much. It's been a great day. So much discussions and presentations have gone on. But we have some homework to do. We need to make this world come to terms with the reality that there is not enough care, and particularly safe surgical care, being provided to the world, to those who need it. Very often we say, well, what can we do? It all starts with, let us do something about it. Because all solutions will not be found overnight, but at least the fact that we wish to do something about it is half the battle won. But what can we do? I think maybe we start at the beginning. We start with protocols. We need to have some protocols. You need to have a guideline. You need to have a plan. You need to have a design. If I want to build a house, I need to have a plan first. Protocols give you those guidelines. And once you've developed a protocol, you say, who's going to do it? How are we going to implement it? And if we don't have the training, the guidance to be able to do that, we will never achieve it. And once the training is provided, you need tools. You need equipment. You need supplies. You need water. You need electricity. You need autoclaves. You need sterilizers. You need disinfectants. You need dressings. You need sutures. You have tools and supplies that must be in place to be able to implement those protocols you have set yourselves. And at a regular time, you also need to assess and evaluate and go back to the drawing board and say, what are we doing right? What are we doing wrong? How could we improve whatever we're doing? Assessment is an essential part of the implementation of any major task. And then you need to follow up. How is this going to affect over time, over set periods of time? So it's a revolving cycle of training, of assessment, of supplies, evaluation, and doing it better each time as you progress. The question that I ask myself is, surgery is such an essential requirement. Why has it not been given attention before now? Why has it been overshadowed by other priorities? Better late than never. Now that we have done, we need to do it well. We need to prove to the world that this was a welcome thing that should have happened a long time ago. So with that said, I will hand over to my co-chair to take it from here. And thank you.
Thank you very much, Edna. I think you have caught the essence very well. But before we consolidate that, I think we have 8 representatives of organizations here. We give each of them 2 minutes to make their statements. And after that, we'll have a plenary discussion, and then we try to come to conclusion. But I can anticipate that it will not be very far from what you just have said. Can I ask Dr. Meena to start off with the presentation?
Oh, okay. Okay, very good. I have only 3 slides, which will finish in 1.5 minutes. So, because it's what I said before, that first of all, like we've said, we should be having some norms and standards which would be common for everybody, and this WHO minimum requirements that we have. We've set it already. You've heard about the integrated management toolkit. This needs to be adapted at the country level by all the training programs. And this we could have one voice on that. So this would be like the pizza base, I call it, and everybody else's nice protocols and more importantly, very specific comes over and above that. The next is creating the evidence-based policies. So that will guide us, guide the ministries of health to make a case. And that's very important. Again, a uniform tool, which would again could be used for a snapshot to get a snapshot. What is the assessment in a country of surgical services? And lastly, join the WHO Global Initiative. The reason being, this is the only global initiative in the world, which is by World Health Organization. You've seen many partnerships on maternal health, all other injuries, so many other partnerships, but we never had anything on surgical care. And this is something to have one voice so that we all have a unified voice for strengthening emergency and essential surgical care towards the universal health coverage. Thank you.
Okay. Dr. Harald Veen, on behalf of the International Red Cross.
Thank you. Well, it's very simple to solve this. It's just a matter of doing the assessment, and we've done that. All the global health burden, everything is known. Now we just have to get organized and put it into practice. Few little hurdles, of course. What is a surgeon, for instance? I've got this pool, human resource pool, and even within Europe, in Holland, it's a recertification after 5 years, the Britons soon, every year, and an Italian and a Swedish can just do lawn mowing, and they'll have their license still after 50 years. So, and then we have all the exotic registrations. So there's some problems to overcome. Thank you for the orphan remark. Thank you for the do no harm remark, because we do harm, of course. We know the patients with starving one child to participate in the feeding center. We saw the VVF statistics that it's mostly iatrogenic. We saw the osteomyelitis due to the implants. We do harm. So I think if we start preventing doing harm. So why has it not happened? This is a nice article a few years ago, World Journal of Surgery, 7 Sins of Humanitarian Medicine. Just go through it and you'll recognize all of it. It's just there. When you've been out there, you've seen all this. Organizations going in, no follow-up plan, leaving a mess behind. Actually, it's worse afterwards when they leave with agendas, political agendas, religious agendas, all of that. We've come from very far. I remember the incredible mess in Goma during the Rwandan genocide, where 120, 130 NGOs were competing, and we started talking a little bit, but it's good actually to keep this in mind. Do no further harm. Just have a look. Oh, you can't see it, but who's telling us this? It's the American military. Very interesting. By the way, the one NGO, The one NGO I thought was really harmless in Goma in '94 was a tiny, small American NGO, Mission Blessing. I only learned recently that actually it was a CIA infiltration. So,
time's up, Mr. Veen.
Okay, this is the last one. What do? We struggle, and I just have to be honest, we struggle. Proud ICRC, stuck in the mud. We try to do it well, but it's very difficult to do it well. But our mandate is indeed, once people have started killing each other, so it's a little bit late as well. But it's not easy. Let's try to do better.
Thank you, Dr. Veen. Our next speaker is Dr. Chandrika Rao on behalf of MSF.
So good afternoon, everybody, and I would like to keep to the time. So I am just going to quickly give the opinion from MSF side. What needs to be done? Like we have been talking the whole day today, I strongly feel that we are all duplicating each other's work, and that needs to be reduced by forming an international body comprising mainly under WHO umbrella, and including some of the health ministries of low resource and medium income countries, as well as some of the NGOs. And this body can then formulate all the surgical indicators, the outcome, the protocols and the guidelines, which will be very uniformly formulated, and then the results can be analyzed and audited. And this will give us a better perspective on how to improve the skills. Okay, yeah. So why didn't it happen before? I think it's very obvious and we don't need any explanation on that. So it didn't happen because of all the duplication of the work we have all been doing. There have been too many cooks with not too much of standardized care being offered, and no official designated body was there to monitor the outcome. For example, WHO has this safety checklist, which was formulated after much effort from contribution from a lot of countries and NGOs. And I think that similar structure is required again to formulate a systematic care guideline. And the other contributing factor to not having a proper care is the lack of awareness from the point of view of the patients and their lack of access to surgical facilities. Lack of training both for expatriates and for the national surgeons. Expatriates need to downgrade their skills to reach the grassroots level, and the training of national staff to upgrade. So from MSF point of view, we are trying to strive to do this for the past 40 years, 300 projects in 70 countries. We have performed more than 50,000 annually surgeries. And our goal is to have national guidelines and protocols so that we can give better care. And we also stress on meticulous record keeping and data analysis. By this, we would like to achieve a proper, safe and standard care for all the patients. Thank you.
Thank you. 2 minutes is not a long time, eh? So our next speaker is Dr. Maurizio Cardi from Emergency.
Thank you. What needs to be done? Well, for us, it's very important to carry high standards of cure, free of charge for everybody, to break the barrier with the poor, and invest in infrastructures and as the partner commitment to reach the poor and pursue the goals of global health and ensure equity. So why all this hasn't been done, but probably is not happening even now, right now. Surgery, we know, has long been neglected as a priority, with the result, only basic surgical services with unacceptable minimal standards and no global fund for surgery. Surgical services are concentrated in big cities and reserved to those who can pay for them, and not enough surgeon familiars also with non-operative skills, logistic, training and financing, which you need in low-resource countries. And of course, last but not least, surgery is highly complex. So what is the role of our organization, of our NGO? We work in close contact with local authorities to guarantee ownership and pursue the final goal to lead the project to run. We try to keep as much as possible high standards of care, free of charge for everybody, and we build or rebuild our infrastructures and provide in Afghanistan a unique field referral system for the patient. And we provide high-level training for local staff, residents from Afghan MOPH, and we do a lot of partnerships also to send Italian residents and fellowship to train in our programs. And of course, we use simple clinical protocols and implement monitoring of the standards of care. Thank you.
Thank you. Dr. Susanne Meiser, sorry, Dr. Cotton. So, Dr. Cotton, Mr. Cotton, ICES.
What needs to be done? If we're talking about essential surgery, we need to define it. And up till now, this hasn't been fully accepted and certainly hasn't been fully done. We've proposed a list of 15 procedures to be included as essential surgery. We want to put this on the ground, and this is where we're going on that. We need to demonstrate the cost effectiveness of this surgery, provide the feasibility of this, and advocate it as a solution. Why didn't it happen before? Really, I don't know, but it was mentioned 30 years ago in The Tropical Doctor, 20 years ago by Professor Eldred Parry, 10 years ago by John Rennie. I think now the deaf ears have been declogged. Surgery was thought to be complex, expensive and needing specialists, but it's now known that this is cost effective, and there is a superfluity of surgeons with inadequate experience in rich countries. What is the role of ICES? Lobbying for surgical recognition as primary care, lobbying for the use of non-physician clinicians as essential surgeons, completing pilot projects to prove the point, introducing modular training programs, and establishing certification of qualifications of non-physician clinicians. Thank you.
Thank you very much. Dr. Susanne Meiser from the German Tropical Society. I have no slides.
I wanted just to have a few words to the German Society for Tropical Surgery. As a small society, it has been founded in 1992, and our main role we see to try to organize a forum and then to exchange our knowledge with other organizations or other people from other countries and to learn from each other. For this, we organized every 2 years an international symposium where we invited people from countries doing surgery in low resource settings. And we organized workshops for younger doctors and medical students where we trained them on basic surgical skills such as normal sutures or bowel sutures or external fixation, just to raise their interest to do the work, to raise their interest for our work. What has to be done? I think this symposium shows how important it is to exchange the ideas between the different organizations, so we don't have, the organizations don't have to be deaf, blind or mute for each other, and just to work together to work on the main aim to provide surgical care for everybody.
Thank you. Peter Reemst from the Netherlands Society and the International Federation of Rural Surgery.
Good afternoon. Well, I take only one slide. We have founded, not we have founded, Indian surgeons have founded this International Federation of Rural Surgeons because the establishment in international surgery is not anymore any platform for whatever surgeon in the world does. If you are a surgeon in Africa or in India, you're completely isolated. What we want to do is to join forces and to keep this surgery, which these isolated people are doing, with a surgical international establishment. Because in this international surgical field, we need appropriate surgery for people who gain $1 a year. And then every single method you can find in any hospital, if you go here in Amsterdam, is not affordable there. But we have to keep contact with these surgeons. They are completely working on their own. What we do, in fact, is give them a platform, have discussions together, so that surgery is one surgeon worldwide, and we have to take back our responsibility for these surgeons which are working under these very difficult circumstances. In fact, it's the best surgery which you can give, because 4% only can have access to this surgery. Thank you.
Thank you. And last, but certainly not least, Professor Jani, on behalf of COSECSA.
Thank you very much, Mr. Chairman. I was asked to talk about improving surgery in the COSECSA region, and I was also taught as a surgeon that get it right and don't worry about time. So, what needs to be done? In the COSECSA region, what we need to do is improve the hospitals so that we can improve training. Simple. Why didn't it happen before? As I said earlier, for the governments in that region, health is not a priority because of the economic situation. Economics and corruption all lead to bad surgery. What needs to be done? What is your plan to make this happen? The COSECSA strategic plan. It's on the COSECSA website, www.cosecsa.org. You can check that out. I could take an hour going through that for the next 10 years. But with assistance, we need to improve the hospitals and training through partnerships. At the last session in room 4, I was told that 50 surgical missions emanate from Netherlands to Africa. That was the last e-learning session. If those 50 sessions were concentrated on 5 hospitals, we would have produced 500 surgeons over this time. I'm not saying what we did in the past was wrong, but there are stages in life we go through. First, as I mentioned, the ship surgeons, then the missionary surgeons, then the medical schools came into place, and now we are at a stage where we need to focus and train the right person to do the right job thoroughly and completely. So visiting partnerships, and what we need to do is improve hospitals, okay? We may put skills lab, we need a visiting faculty program. Those who cannot come there and work there for a long time, come as visiting faculty. The American College of Surgeons has this program on the website. We get the visiting faculty, and they're doing a great job. And then double the current number of trainees in 3 years, and do not double the efforts to do that. Thank you very much.
Well, thank you, Professor Jani, and thank all the speakers for keeping on time. A lot of things have been said, and I think before we have a discussion among the members of the panel, I would like the audience, if there is any theme or aspect or issue that should be mentioned and that has not been mentioned. So don't repeat what all these wise people have said already, but is there anything that you feel that should be said, should be mentioned, that hasn't been done? So.
Hello, my name is Matthias Richter-Turtur. I'm also a member of the DTC, and since a long time involved a bit in surgery in poor countries. I think the one thing what has not been said is that we all agree as surgeons what is necessary, but we all cannot imagine how few politicians know about the importance of medicine and especially surgery. You see, even if you invest billions for malaria programs, the basic of all these preventive programs is the district hospital and is the operative medicine. And we should, I think, one of the most important points is that we as surgeons go out and tell the non-medicals and the non-surgeons how important these things are, because since the conference of Alma-Ata, it has been a bit forgotten how important surgery is within the the primary health care. Thank you.
Okay, so the policy makers.
Hi, good afternoon. I'm Jamie Henry, and I just wanted to let everyone know that in the last 2 years, there's been a loose coalition of about 30 organizations that have been working together to advocate for surgery and the global agenda. This group includes the Lancet Commission on Global Surgery and other groups, including ISIS as well. And one of the things that this group has done is to really work with politicians and ministers of health to support surgery that has resulted in the WHO resolution. So this loose formal of organizations is now talking to make it more formal, and there's an idea of the alliance of surgical obstetric trauma and anesthesia organizations, the largest professional societies, NGOs, largest bodies of the world, to come together in a formal way to create a structure and to have a fee for paying for someone who would constantly advocate for surgery at the highest levels and to be at the UN as well. And that's something I'd like to let everyone know as a point for discussion.
Thank you.
Thank you. Michael Lawrence, World Orthopaedic Concern. One great requirement is the evidence upon which this practice is based. Evidence-based medicine is essential, it's natural, it happens throughout the developed world. To do that, to transfer that to the undeveloped world is extremely difficult because it depends upon long-term follow-up, investigations, x-rays and so forth, which patients generally cannot themselves afford and they don't realize the value of it. It is essential. It can only be funded from outside and it's going to be an enormous expense. I'd like to see more investment on the subject of research to that sort of review.
Okay, thank you. Can you pass it on? Yeah.
It's very short what I wanted to say. I have nothing heard about the enumeration of surgeons, and especially surgeons who are in teaching hospitals. Why do they not teach in the teaching hospitals what they are supposed to do? Because their enumeration is such that they go to private hospitals and that they do work there so that they can exist. Second thing, the policy which I saw in South Africa, that people who are being sent to district hospitals are getting a higher salary. I think that is a very good policy. People who are willing to go to remote places, they should be enumerated for the fact that they are doing that. I have not heard anything about enumeration.
Okay, one final point, I think.
So I'm Chris Bem. I work in England and in Malawi a bit. So we've talked about evidence, but evidence-based practice, I just wonder whether we should also begin to talk about value-based practice. And when we talk about value, today it seems that Edna talked about something like a dysfunctional economy. And is that not at the moment, one of the pathologies we have at the moment, is that we really have a pathogenic world economy in which the only value that seems that we've talked about is cost analysis, you know, the dollars or the kwacha or whatever it is. And we need to open out the discussion about this. In other words, capital is human capital, social capital, cultural capital, ecological capital. And I think we'll win when we open the discussion.
Thank you. I think there are no more burning issues. One final burning issue from Ethiopia. Dr. Mengistu.
Thank you, Mr. Chairman, for giving me this opportunity. One of the things Dr. Meena said is that we scan the temperature and also we talk the language of the public health people. And as we all know, non-communicable diseases are given a lot of attention. And is there any way we can move with the wave in defining at least some of the essential surgical things included as non-communicable diseases? For example, injury. If you put among the most common non-communicable diseases surgery, this can really take us to some point if we move with the wave. Thank you.
Thank you. Yeah, I think the wave is there. We are all together now, and we are all of the same mind. And the question is, how can we put this wave into something that really has impact? Edna, if you have an idea.
Well, I think we need to put this down. We need to come up with a declaration. We need to come up with something that comes out of those 2 days of very intensive discussions. And this would probably be the basis upon which we can build future activities and where to take it from where we can take it forward. So if my co-chair has any ideas on how we can go about doing that, do we have can we come up with a draft? Can we come up with a decision? Can we come up with some a declaration? Alma Ata came with one, Health for All, many, many, many decades ago. Why not come up with Surgery for All? Amsterdam Declaration. Why not?
All right. I think that's a very good point to start with. Can I make some proposals and then hear from the platform if they agree? I think the common points that have been mentioned is that we need a definition of and protocols for essential surgery. Is there anybody who disagrees? Good. The next point is the training in essential surgery and the methods of assessment. I think those are common things that we all agree on. And the third point, and Edna mentioned them already, is that we need the supplies, we need the tools, the facilities, the drugs, instruments, sutures, and etc. to perform essential surgery. Again. Good. But then, and that has been mentioned, yeah.
I think what is important if you talk about essential surgery is that it should not be second-hand surgery. I give a small example. We do a colon resection. Then in the establishment, internationally, they do it laparoscopically. If we write down that colon resection, that the guideline is laparoscopic resection, we exclude 80% of the world population to ever had elective colon resection. So we should pay attention to the fact that this essential surgery is as equal and as valuable as any other surgical procedures done within all these very established surgical institutions.
Good point. Thank you. What has been mentioned by almost all the speakers here, but also from the audience, is that we need to advocate this, to bring this to the policymakers, the non-surgeons, from WHO to national and local regional governments, to gain them for surgery, and as was said, to make the wave happen at policy level. Then the financial side. When I was a medical student, I was taught that there are 3 motives in life of men. And the first is money, the second is power, and the third is libido. Well, I think the last, yesterday afternoon, evening, and today, there has been very little of these 3 motives. And I think we are all here united, not because we are saints and not because we don't need money and we can live from the wind, but because we think there are other values in life than the things that we just mentioned. But that doesn't take away that we need to live, we need to eat, we need to send our children to school, and we want to give them a future as well. So it's certainly a point that should be taken into account, that if you want to perform surgery, you should be remunerated for that. Again, no objections, I hear. In the way of implementation, I think there should be a strong move towards partnerships between countries, between universities, between hospitals, societies, twinning or whatever you call it. It's a good way to involve people, even the people who cannot go out, but they can still do teleconferencing, giving advice, consult online. There are all kinds of methods how we can communicate, and from the West we can assist people in the low resource countries, and the other way around, they can teach us. Because, if there's still no objection, I would like to extend the idea of essential surgery a little bit to the Western societies, because I think a lot of surgery is done in this part of the world that is non-essential, and a lot of money is spent on that. So I think if we develop that concept of essential surgery, we should also look at this part of the world. Again, no objection. Ah, two hands, good. Because otherwise it's a monologue.
I just wanted to add a dimension to the conversation on essential surgery, where there are two ways to look at it. It's either a problem or a solution. And we need to decide which angle we're taking this on moving forward, meaning are we talking about essential surgical diseases, which means, you know, every single country will have a different way of solving that problem, but, you know, the condition is there. Or an essential surgical intervention that can address a certain type of problem. And those two can be confused and can be interchangeable in some respects.
Okay. Dr. Richter.
Sorry, can I add one point also? I think, at least in Germany, we have the problem or the situation that we are tending to more and more specialization. And that means that essential surgery or general surgery is getting lost. We even have a new, we will have a new regulation of specialization where general surgery does not anymore exist. And I think that we should also advocate and promote under our own colleagues who are not perhaps interested so much in the surgery in the poor countries, but at least we should inform them and keep them open that this exchange with developing countries and the exchange with the colleagues from Africa or Asia keeps on important, because they are treating the biggest part of our globe. So I hope that our German colleagues are not closing up and saying, we are not interested in that. We should support that.
Okay, thank you for that remark. Now, from this side of the room, it has been rather quiet. Can I give one of you?
Included in remuneration for the surgeons need to be certification and monitoring and mentoring. This is essential, even for those who think they know that they're doing it properly.
So that is part of assessment and followed by certification. Yeah.
Sure, speaking about recruiting also it's very important. General surgery, we have difficulties in finding surgeons. For example, in one of our hospitals we do kidney stones, and the only way in Afghanistan to operate to remove a kidney stone is to operate these people, and nobody in Italy is able to remove openly a kidney stone. Nobody can do that. So they ask for general surgeons, but the general surgeons today is not able to remove a kidney stones. So in the near future, nobody will ever be able to remove a gallbladder by open procedure, just laparoscopically. And this is incredible, I mean. And the other thing, just briefly, we have, for example, in Italy, a program, MOPH permit us to, if we work in a hospital, to leave the hospital, for example, for 6 months. They cut the salary to 0, so you get paid only by the NGO if the program is recognized. So this is quite good. But of course, the best target would be a professional which is between 40 and 50, 55 maximum years old. And in this period of your life, you earn money normally. If you are a professional, you have family, you have kids, so it's not easy to leave your home for nothing, and for nothing or for very, very low wages and for a long time. So that's a problem also.
I think we have a burning question from WHO.
On two topics I want to just respond. One is on the essential surgery. So I did show there is a primary surgical care package in which we put what would be the essential surgery in both in the health centers and in the district level. So people could take from that and adapt it to the countries what they would think. Each country has their own priorities, but this is something which was formed for global adaptation. The second thing that we have not discussed, and I think Dr. Tutur raised that, is about advocating to the policymakers in a very simple language, what is surgical care? How does it affect? And I think Dr. Asrat also mentioned the same thing, that we have to make it simple so that politicians, policymakers who are not surgeons, how do we say to them that surgical care actually services, if we have access, cuts across all non-communicable disease, everything, all across. And that's the message that so far we've been talking among experts, that surgeons we all understand, but we are not getting that word out in a simple language. And this is something all of us have to do it.
MSF?
Again and again, we have been talking and discussing about the skills and the training that we have in the urban world versus what is required in the remote area. And recently, just an example, I'll give you a funny thing happened. After a lot of briefing of a surgeon from this part of the world going to Africa, and I elaborated on the surgeries that she would have to do there, end of it, I asked her whether she had any doubts. And the doubt was, will I be able to perform laparoscopic surgery there? So, you know, this is the mindset now, because this is the training we get in developed countries or urban societies. And this is not really essential as of now in the areas where we are operating at present. So with this in mind, MSF is zeroing on a project, a hospital, where all our first mission volunteers could go and work for 6 to 8 weeks to hone their skills in remote setup surgery. So with that, they'll be more confident to be sent out to other missions and other projects and not feel overwhelmed or lost or stressed.
That's the training aspect. Thank you very much.
And I think,
Edna,
if I may, before we leave the training aspect, I think we're all focusing on the surgeon. We mustn't forget that there's a whole team around the surgeon. No pilot can fly a plane alone. There are others in that plane who keep that plane up in the air. So we mustn't forget the other members of the team who keeping that surgery safe. And I think there's a hand there.
One final word from Dr. Winters, and then we have to wind up.
Thank you, Heij Winters, Amsterdam. I think we should be very careful about definitions here, because what we have seen as what we define as essential surgery, we should not confuse that with general surgery, because it's not. If you look at the 15 by 15, you see, at least in terms of the Western world, we see at least 5 or 6 specialties involved. So let's not make the mistake to think that we have essential surgery, which is something that comes from general surgery, because it's not. So what we're actually doing, and I don't think it's wrong, I mean, there's nothing wrong with that. What we are doing, we are defining from the specialties that exist, the things that we think are essential for developing countries. And it's perfectly all right to train a surgeon or a doctor to perform these 15 types of surgery, but it's not as a general surgeon. It's a doctor that's trained in essential surgery, and that's a difference. And I think it should be. It's good to emphasize this, and it's perfectly all right to start like that, and then from there you will see that when the system develops and the demand for more surgery than only the essential surgery arises from this essential surgery, the other specialties will arise because there is need for more surgery. But that's on the long run. We should start somewhere. Essential surgery, fine. But let's not say that's general surgery at a certain scale, because it's not. It's 5 different, at least 5, maybe even 6 or 7.
But you agree that a doctor who can perform these 15 operations is a very general surgeon?